This is basically a talk on the behalf of Dr. Chetan Deshmukh sir, senior medical oncologist from Pune. Unfortunately, because of some unavoidable circumstances, he couldn't join. So I'll be presenting on his behalf. So this is basically another ALK1 inhibitor, NUV655 in advanced lung cancer. Actually, I was discussing just some time back, really I think ALK1 patients might become immortal after some time, because we are going to have so many other lines of therapy in ALK1 that definitely the survival is just crossing. The Paul Ehrlich has coined a term called magical bullet. I think the imatinib was somewhat close to it when it has actually came. After that, there is nothing, and I think next, the target, which is actually is reaching a magical bullet, is ALK1. So it is a receptor tyrosine kinase. ALK fusion, EML4, ALK are known oncogenic drivers in 3 to 5% of NSCLC. So this is a regulated ligand-dependent signaling, which is a normal. Well, ALK fusion is a fusion partner is EML4, which is a constitutive ligand-independent signaling leading to unregulated proliferation. Now we have already discussing so many ALK inhibitors are there. We also had a panel discussion, and there are 6 tyrosine kinase inhibitors are already approved. First generation is crizotinib, second generation is ceritinib, alectinib, brigatinib, third generation is lorlatinib, and ensatinib is on its way to getting approved. So we will be always keep discussing, which is the first, whether we should be doing sequencing or put a best foot forward. But I think everything, sometimes these patients are going to progress, and then what next? If you are using especially like lorlatinib upfront, then what is next? So in spite of this treatment, first and second generation TKIs, 40% of the patients, they develop G1202R solvent front mutation, and it confirms resistance to crizotinib, ceritinib, alectinib, and brigatinib. Though lorlatinib has been approved in such a resistant patients, compound mutations like with L1196M, with L1198F, and with G1269A, it has been observed in this patient after progression after lorlatinib. But still, there is a search for better and more potent ALK inhibitor goes on. So another discussion which was happened, if we are taking a ALK inhibitor which is more having a CNS penetration, whether we are having all these CNS related side effects, cognitive impairment, mood disorder, sleep disturbances. So basically the basic mechanism is tropomyosin receptor kinase, that is TRK kinase ABC. These are neurotrophic kinases, and they are structurally similar to ALK. So we cannot really have an ALK blockade, and that is difficult, and that is the reason why more CNS penetration with these ALK inhibitors, we are seeing these more neurological adverse effects. So NUV655, it is efficacious. Now this is a xenograft model BA53, which is a promurine. These are cells which are usually they are IL-3 dependent, and they do not have basically a direct growth potential. They totally depend upon tyrosine kinase inhibitors, and these are the cells which are utilized for tyrosine kinase inhibitor studying. So we can see here in this graph, look at this tumor volume, this one of NUV655 at the dose level of look at 0.3 milligram per kg and 1.5 milligram per kg, we can look at the tumor volume, while the same with the lorlatinib, we can look at the resistance pattern after 14 days of treatment. So this was something basis to consider NUV655. So there is comparison of various tyrosine kinase inhibitors, and look at the sparing of TRKB. Now this is what is most important when we are having a neurological side effects. With lorlatinib, there is a 5-fold selectivity for G1202R, and it can spare, while NUV655 definitely it spares TRKB, and that will essentially reduce the neurological side effects which are associated with CNS penetrating ALK inhibitors. So it has designed selectively inhibit ALK while sparing TRKB, showing 43 to 484 times fold selectively window depending on ALK mutation, and by comparison lorlatinib only shows 5-fold selectivity. So ALK-TKI, what is the future? In non-CNS penetrant wild type, we have crizotinib. In CNS penetrant, we can use ceritinib, alectinib, brigatinib, ensatinib, and lorlatinib. Well, CNS penetrant and double mutant ALK-TKIs, TPX0131 and NUV655. So to summarize, it is a potent, selective, brain-penetrant ALK inhibitor as demonstrated in vitro as well as in vivo studies. It is active against G1202R plus mutations, including the compound mutations L1196M, G1269A, and L1198F, which confirms resistance to all other approved ALK therapies. It is selective for ALK and ALK G1202R plus mutations over TRKB, indicating the potential to minimize the TRK-related CNS adverse event and drive more durable responses for patients. Thank you very much.
Thank you, Dr. Ashay.